In part one of this program, we examined the causes, physiology, and symptoms of heart failure. We also discussed the Frank-Starling curve and the compensatory mechanisms of the heart. In part two, we will examine decompensation, diagnosis, and the American Heart Association classification system for the staging of heart failure. This program concludes with a brief discussion of current medical therapy. Compensatory mechanisms involving the heart cannot be sustained for very long. Ventricular hypertrophy becomes self-defeating. Cardiac remodeling not only increases muscle mass with increased oxygen requirements, it alters flow within the heart, increases chamber size, and even changes the position of the heart within the chest. These changes further injure the heart tissue, depress cardiac output, and may even lead to mitral valve incompetence and regurgitation. Arrhythmias like atrial fibrillation and premature ventricular contraction can arise. To promote homeostasis, the body produces natural vasodilators and B-type natriuretic peptides. But as heart failure progresses, these chemicals lose their beneficial effects. Arrhythmias may worsen, including the potential for sudden death.
So in heart failure, the pump is really failing. The congestion backs up, you get this abnormal pressure gradient, and it allows the fluid to actually go from the blood vessels and into the tissues.
The patient begins to experience distressing symptoms. The fluid retention of the renin-angiotensin-aldosterone system may lead to fluid overload. When the heart can no longer process the flow as fast as it's pouring in, fluid begins to build up in the lungs and body. The situation is somewhat comparable to that of a leaking boat. Two sailors are enjoying a lovely afternoon in their dinghy, expending very little effort as they happily drift along. Captain Frank realizes that it's getting harder to paddle. The boat is sitting a little lower in the water and moving more sluggishly. He recruits his crew to help them move along. With both of them paddling, the boat is up to speed again, and all appears fine. But once again, the boat slows down, in spite of their best efforts. Captain Frank makes an unhappy discovery. Water is coming into the bilge and lapping around his feet. Thinking quickly, he grabs a bucket and begins bailing. But he can't bail fast enough. The water rises. He alerts the crew there is no more hope of going forward. Now they must work just to stay afloat. As the water continues to pour in, they bail harder. The water continues to rise, so they bail faster. The water is still rising. Dr. Frank hands his crew the emergency bucket. Like myocardial hypertrophy, the larger volume allows more fluid to be moved with each effort. But the workload is increased. Even with their best efforts, the water comes in faster than they can get it out. As the water continues to rise, the work of bailing becomes too hard to sustain. The compensatory mechanisms fail. The sailors are exhausted. Decompensation sets in. The boat is overwhelmed with water and sinks. The sailors are too tired to swim. Physical examination of a patient with heart failure focuses on those areas that reveal increased fluid volume and decreased circulation. Dyspnea, a cardinal sign, may not be observed when the person is at rest, but may be reported in the history. Moderately severe heart failure produces enough pulmonary fluid that rales or crackles will be auscultated in the lung bases. The increased adrenergic stimulation may be manifested as an elevated heart rate or an irregular cardiac rhythm. Cardiac auscultation may reveal a third heart sound, called an S3 gallop. Ventricular dilation may cause valve incompetence with a murmur present. Jugular venous distension is a sign of increasing pressure in the venous system. Prolonged systemic venous hypertension can also cause ascites. Peripheral edema may be present, depending on how much fluid the person is retaining. Another sign of water retention is weight gain.
How can we find out if I have heart failure?
One of the most accurate tests to determine the severity of heart failure is the blood level of B-type natriuretic peptide, or BNP. As cardiac pressure and volumes increase, BNP is released from the ventricular myocytes into the blood. BNP acts as a vasodilator, promotes the excretion of sodium, natriuresis, and antagonizes the renin and aldosterone release that causes harmful hemodynamic changes. Other lab studies include a complete blood count, serum electrolytes, cardiac enzyme levels, urinalysis, blood lipids, thyroid function tests, and tests to determine renal and hepatic function. Pulse oximetry can be used to assess oxygenation at rest or with exertion, or to determine the efficacy of supplemental oxygen. A chest X-ray is also important when evaluating heart failure. An X-ray will show the degree of heart enlargement present. It will also reveal whether rising pressures have caused pulmonary edema, pleural effusions, or thickening of the interlocular septa, called curly V lines. An ECG, or electrocardiograph, should also be done. Although the findings may be nonspecific to heart failure, an ECG may show left atrial enlargement, left ventricular hypertrophy, axis deviation, arrhythmias, ischemia, and bundle branch blocks. Echocardiography is an inexpensive and easy way to determine both systolic and diastolic function of the left ventricle. It can reveal cardiac chamber size, ventricular wall thickness and motion, valvular incompetence, and degree of cardiomegaly. Other imaging studies include cardiac catheterization, nuclear imaging at rest and with exercise, and radionuclide ventriculography. The American Heart Association has devised a system whereby the degree of heart failure can be classified according to 4 stages of severity. Stage A. These people are asymptomatic, but they have risk factors like diabetes and hypertension that predispose them to the development of heart failure. Stage B. These individuals are also asymptomatic with risk factors, but they are already experiencing changes that indicate compensatory mechanisms have begun. Although they are not experiencing shortness of breath or peripheral edema, they may have left ventricular hypertrophy or decreased left ventricular function. Stage C. This group comprises the bulk of heart failure patients. They are either having or have had symptoms of heart failure with known structural cardiac disease. Stage D. These patients are experiencing heart failure that is refractory to treatment. They are dyspneic at rest, have varying degrees of renal failure, and systemic venous congestion. They may be thin, pale, and exhausted, exhibiting a cardiac cachexia due to prolonged anorexia and an increased metabolism. Patients who are in stage C or stage D of this classification are further described by another system, the New York Heart Association Functional Classification System, which is based on exercise intolerance. Treatment for heart failure is an important priority within the medical community. Because this is a syndrome arising from many illnesses, The underlying cause must be identified and treated. Often, the only therapy available addresses symptoms rather than causes. Activity must be limited in order to reduce the cardiac workload. Depending on the severity of symptoms, this may require bed rest in an intensive care unit. The preload can be reduced in several ways, including medications like diuretics and ACE inhibitors. Intake of sodium and fluid needs to be limited too. Afterload can be reduced with vasodilators. Contractility can be improved with supplemental oxygen and inotropic agents. And adverse neurohormonal responses can be blunted with diuretics, recombinant BNP, and beta blockers. Although we have made great strides in the treatment of heart failure, our biggest challenges are yet to come. If heart failure doesn't touch you, it will touch someone you know. As we live longer lives, overcoming ischemic cardiac events, congenital and valvular disease, and cardiomyopathy, it is inevitable that the incidence of heart failure will continue to increase and dominate our medical dollars. In addition to intensive research, we must rely upon a good understanding of the pathophysiology of heart disease to help us recognize and treat the symptoms early, before permanent damage is done.
That will be it for today. That's just a representation of, mainly because heart failure is such a big deal and we have so many people that are hospitalized. Actually, if you look at the numbers on any given day for patients 65 and over, the majority of them are hospitalized for heart failure. So that's why it's a big deal. We will see it on test. So tomorrow we'll have a couple of, more than a couple, but we'll have some scenarios that we're going to do in class, and then we will start back with the peripheral arterial and peripheral vascular disease.